Hi everyone, my name is Dora Karavasilis and I am the Knowledge Translation Lead at NCCRED. And as a member of the NCCRED leadership team, I'd like to thank you guys for coming to our symposium and welcome you here. And I'd like to thank Elder Frank for welcoming us here to Ghana country and recognise that sovereignty was never ceded. Today I have the pleasure to talk about a project I've been working on for around the last 10 months in my role as Knowledge Translation Lead, and we are developing an internet-based cognitive behavioural therapy, or iCBT, program for people who use methamphetamine. So we set out to develop an online therapeutic program for the This Way Up clinic. So This Way Up clinic is St Vincent's Hospital Sydney's digital mental health clinic, where they have a range of different self-directed programs for conditions ranging from anxiety to depression, insomnia, chronic pain, etc. And all of their programs are based on classical CBT. So that's CBT rather than any of its derivative therapies such as acceptance commitment therapy or dialectical behavioural therapy. And our vision is that it could be used as a standalone treatment. So people could jump onto their computer independently and say, I need some help with this, and be able to find evidence-based treatment right there whenever they need it. But also we envisage that it will be able to be used as an adjunct treatment, so clinician assisted by either allied health professionals or the non-professionalised or AOD support worker, peer worker type care models, offering evidence-based CBT activities. We also envisage that it could be used as a research tool. So, I mean, very briefly, I'll touch on a little bit of the evidence base there and some of the questions that remain in, this type of product, but we sort of envisage that down the line it could potentially be used firstly to answer some of the questions about internet-based help for people who use methamphetamine in the first instance, but then potentially as a research tool such as control arms or things like that in randomised control trials or other clinical trials that we do. Therapeutically, we set out to support people who use methamphetamine to change their relationship with methamphetamine rather than emphasising abstinence-based approaches, I suppose, where we know that sort of embedded within harm reduction philosophy is that just say no style messages aren't really that effective. But also this arose from some consumer consultation we did around this, and the people were really saying we want sort of tools and strategies to kind of to work with this rather than just sort of hearing that consistent, just stop. Although, so the program in its design offers people, whilst providing that health promoting message that certainly not using it all is certainly the safest, but, there are tools and strategies there. And so in terms of the case for an iCBT, I mean, do we need one at all? Is the evidence base there? And I mean, I'm sure given NCCRED's primary business, we'll hear this a few times today, but there are no approved pharmacotherapies for methamphetamine use disorders. And so there's psychosocial interventions need to be the first line. And so, yeah, but there are a few, in the evidence base is quite kind of mixed for CBT. For instance, one systematic review found 8 out of 44 studies use CBT towards methamphetamine use disorders. Some of them use CBT elements, some of them were sort of LGBTQIA specific CBT programs, and in general, the results were sort of favourable, but as we can appreciate, there's not a huge amount of information there. But in general, CBT is considered to be safe at worst and effective for a range of different conditions. That said, the This Way Up model for iCBT, they've got quite a robust evidence base for a range of different mental health conditions. So anxiety, depression and insomnia and chronic pain are all have good evidence to sort of show that model might be effective. In regards to digital health for internet-based iCBT for methamphetamine use disorder, to the best of our knowledge, this is one of the first that are out there. There are some, in my research, there are some sort of cocaine-based treatments coming out of America and things like that. In Australia, most digital health interventions at this stage are geared towards alcohol or tobacco. And so this definitely represents a really emerging space for us to dig a bit deeper. And so just at the face of it, we know that people who use methamphetamine one of the biggest issues is treatment access overall, where uptake is very low and there's a significant treatment access gap of around 5 to 10 years estimated. I've even seen it up to 13 years between the first time a person experiences a difficult or harmful symptom from methamphetamine use and the time that they seek help. We also know that treatment access is gendered. So, for instance, women users equally to men, but represent less than 1/3 of treatment seekers. And some review of that suggests that that may be linked to access to suitable family care and women's roles as primary carers, as it often is. We know that people in regional areas, the harm is unequally distributed to people living in regional areas, and that many people who are seeking treatment have to travel more than 1 hour to receive care, and that's not really a marker of a good situation. But we also know that recreational use is declining and dependent use is increasing, but that there is a significant unmet demand, estimated at between 75 to sort of, I think it was 46% or something like that of unmet demand. So, less than half beds available to beds that are required to meet the demand there. So just at the face of it, without even going in, and I don't have a huge amount of time left, at the face of it, without delving too deeply to that, we can see why an internet-based therapeutic model might be an effective way to put something where there isn't currently and help people get effective and evidence-based treatment easily. So just to very quickly touch on the therapeutic journey, we've gone for a 4-session CBT model. I guess that's a pretty standard sort of CBT approach, which is why we've done that. Again, the evidence base, there's a lot of difference in methods that people have tried, and so we've chosen a 4-CBT approach, and it follows a fairly standard, let's say, treatment pathway, starting with motivational enhancement and goal setting, moving into information about cravings and craving management strategies and drug education, moving into sort of what's called maintenance or cognitive restructuring, behavioural activation. We've put some bonus content around sleep in there, and moving into a relapse prevention module. Again, it's important to note, I think, that we've de-jargonized the program. So this type of language doesn't necessarily exist within the program itself. In regards to the product design and development approach, given that we were setting out to trial a cognitive behavioural therapy model, it didn't seem appropriate to sort of have a full consumer co-design, because we didn't want to fall into that pseudo co-design where people aren't able to really, affect change over the program. So the program itself has been designed with a clinical group, which we've established, and it's sort of an iterative co-design space with consumer involvement. So far we've had a couple of different consumer groups, and they're very much informing the sort of the feel and the experience of the program, and that's sort of feeding into a clinical co-design space. In regards to just the product development process, we're sort of at the end. I guess in a lot of ways, this presentation is very much like a watch this space, because the product isn't ready yet, but we are hoping, we are getting towards the end of the first phase, which is where we've got a very nearly complete program, which following that, we will go into a product development phase. So once we've got this clinical co-designed documents, we're going to take that into a consumer co-design phase of really informing the experience of using the product. Hopefully, all things going well, we'll have an RCT ready to go around the middle of next year to examine its efficacy, as well as looking at qualitative factors, and potentially next year I'll be here able to share some results from that, hopefully. That said, all things going well, we're hoping that sometime in 2025 there'll be a product that will be available on the This Way Up platform that anyone will be able to access and use and benefit from. And so if you are interested, on the back of the program there's a QR code. It's the same one there. So subscribe to our newsletter if you want to hear more exciting updates. And I did it. It's like 17 seconds left. It was so I believe there's 3 minutes. Does anyone have any questions?
It's coming with a microphone. I'm really curious about curious about something? Yes, good. I'm curious about the people involved in the co-design and whether or not they were people who were treatment naive. Were there people who'd been through CBT type programs before, or were they people who just identified as using methamphetamine? Can you just tell us a little bit about who was in that cohort?
Yeah, that's a really great question. We did recruit people for the focus groups and for the further consumer testing from the stimulant treatment service at St Vincent's Hospital, Sydney. So I guess in general, they're not a treatment naive population, rather they've already engaged with the service. And that's, I think, most people who do this type of work can appreciate can be really, really difficult to get the right people to feed in the right information. So that's the approach that we've taken as well, given that St Vincent's is our clinical partner. Anyone else? Any other questions? I just realised I did go over time because it was a 10-minute timer, not a 7-minute timer. But
Well, we have this spare time, but we will move on to the next speaker.
Cool, thank you.